know that waiting lists aren't just numbers, they are people and often waiting for life-changing procedures. So what we're going to explore, we're going to look at predictive analytics, essentially using data to see the storm before it hits the emergency department. We're also diving into hospital at home or virtual wards, because this isn't just about freeing up physical beds, it's about the clinical evidence that shows patients often recover faster with fewer complications when they are in their own environment, supported by remote monitoring. So please welcome for on our panel to discuss this in more detail. We've got, she's a friend of the show, Dr. Faris Al-Ramadani, Innovative GP Partner at St. Wolfson Surgery. Faris, it's always a pleasure having you on. Thank you. Welcome.
Thank you.
We've got Amanda Sullivan, Chief Executive of NHS Derby and Derbyshire, Lincolnshire, and Nottingham and Nottinghamshire ICB Cluster. Welcome, Amanda.
Thank you very much.
And we have Ruth Bradbury, Senior Programme Manager of Digital Health London. Welcome, Ruth.
Thank you. Good to be here.
Thank you so much for all being here. And it is one of those, it's going to be emotional, it's going to be a topic. And we did say that we're going to solve it in 45 minutes. And that's what Faris said. So here we go. Don't hold me to this. But let's talk about the state, and should we talk about where we are right now? Because I think when we mention, if you said the words, the letters NHS to most people, the first thing they'll think in their head is long waiting lists, of course. And it's become one of the biggest concerns with most people. But from your perspective, and I go around, what are the root causes behind the long waiting list that we're seeing right now? Because I just want to get set thing, and then we'll go on to tackling this in the future. So Amanda, for you, what's the main cause?
Yeah, thank you. And it's really good to be here. I think in terms of the causes, I think there's a number of different causes. And I'm obviously looking at this from a commissioning perspective. I think first and foremost, we do know that the demographic of the populations that we serve has changed. And we know that people are becoming ill earlier in life for some conditions than would have previously been the case. And so therefore they're having to enter into healthcare earlier than, in life than they would have done previously. That might be a long-term condition or multiple long-term conditions, but we do know that people's life expectancy has been relatively static, but the healthy life expectancy in terms of how long people live without any conditions is reducing in some areas. And it is unfortunately very much linked to people's general circumstances as well and lifestyle. So we do know that in areas of higher deprivation, there is more ill health and people may present longer. So I think there are some population causes.
Okay.
I think there are some other causes which are more positive in that we can do more now. And so there is more things that people can be referred for and more activity that can be done. So some of it is population driven, some of it is more driven by there's more we can do, more treatments we can offer, and therefore people get referred for more treatments.
Yeah.
And then also I think we still haven't fully recovered operationally from COVID, which I know was quite a while ago now, but I think there are some operational issues there, and I think that lends itself to more reform in terms of pathways, patient choice, patient control over their pathways, as well as really thinking how we prioritise the use of resources. So that's really from a commissioning perspective, Gail.
Yeah, and it feels like we are in a bit of a backlog, aren't we, at the moment? And it's great. We're going to talk about how do we tackle this, but do we have to identify the causes to start with, Faris, or do we just try and go in and tackling, or it's got to be something we look at, right?
Yeah, absolutely. And I think the important thing to know is there's not a silver bullet. You're not going to do one thing that's going to fix the problem. And you've got to kind of imagine healthcare to be sort of like this mosaic, really. There's lots of different things going on at any one time. There's technology, but there's also human behavior. There's human interaction. So it's a very complex web. But I think it is really important that we try and break this down as best we can, because the more we understand what's going on, the more we can try and find those solutions. So from a primary care perspective, you really got to think about things from supply, demand, and then the intersection, right? So from the supply side, that's appointments, that's clinical appointments. Have we got enough people delivering care who can deliver the right types of care within primary care? In order to make that happen, we need the staff, we need the estate, and we need the finance. The money needs to be coming into the system to employ those people. We need training to be right, so we've got the right people being trained to come in. So we need to make sure that sort of from that supply side, we've got the right capacity. But then the demand side, and this is what you were saying, Amanda, we've got more elderly patients, an aging population, more chronic disease, higher demand, higher expectations sometimes. So we've got this sort of rising demand. But that's not, there's not something that's insurmountable. So, the more we do around proactive care, the more we go out and reach out to people and try and treat them earlier, the more that we try and spread good education, make people aware of what they should and shouldn't, or could and couldn't do. There's stuff that we can do around demand. And then we've got the intersection, which is kind of that bit in the middle. So from primary care side, yes, we need to get staffing right. Yes, we need to make sure that we sort of reduce the demand on our services, but we've got to get the middle bit right too. And that's often that 8 a.m. bottleneck scenario where people were dependent on getting their appointment through phoning up. Then they can't get through on the phone. They got to go to work, so they don't get their appointment. So we've got to try and free that up in the middle as well. So that means greater analytics. What's our peak calling time? If that's our peak calling time, what are we doing around workforce so that we make sure that we match supply and demand? So, we're staffing our phone lines more at 8 till 10 a.m. and less so later, because that's when the greatest demand is. We use online tools so that people can use online tools to gain access, to remove that bottleneck. But we don't shut the phones and stick everything online, because then you just create another bottleneck. So there's a lot that we can do. So we've got to really understand, and there's work that we can do to increase the supply of appointments. There's work that we can do to reduce demand. And I love this term failure demand, because I think in primary care, we've got a lot of failure demand, unnecessary appointments, unnecessary work because we didn't get the processes right earlier on. And then we've got that intersection, making sure that people can access the appointments that they need more quickly, more efficiently, more effectively.
Well, and that's it for the wow. And I love the fact, I know, Faris, you speak so passionately about it as well. And what I would say is, like, from someone who's not involved in the NHS is, and I've said this before, is like, we as non-NHS workers or whatever are not involved, we have to take responsibility as well. I don't think it's, you guys are doing everything and the right things. You're doing everything you can. But we live, and I call my kids this, it's an Amazon Prime mentality. They want something now, quick, done, here. And it's like, no. When it comes to you and your health, you cannot just suddenly expect, I should, this entitlement that, that this is this. We are in this situation and we are all part of it, and we all need to play our part right well. And we are obviously looking at the way digital tools can help, okay? And this is going to be our main focus. But at the end of the day, it's got to come from us to sort of here to work out, oh yeah, maybe I shouldn't be doing what I'm doing. Or can I help, from my point of view, rather leave it last minute and then expect something right away. Ruth, I'm going to turn to you, because obviously it's like workforce and workload is the main, we know the NHS workforce are so overstretched. So is it really, can digital tools generally reduce workload, or is it just something we just keep saying and it's not going to happen? Tell us some truth. Tell us it's going to be okay. Sorry, I feel like I've gone very deep and emotional here.
Well, I guess, ultimately digital isn't always the silver bullet, picking up on Faris's comment there. But I think, it has a massive part to play. But, it's not without its challenges. So, we recognise that introducing digital to any kind of pathway or process in healthcare requires change. So it does mean that, you have to have the right people on board who have the appetite to make that change and to see that through. So both from a supplier side and from the NHS workforce perspective as well. And then, getting people to understand how technology can work for them, is a challenge in and of itself as well, and having the right devices or having the right training. So, it's not a case of buying some technology and just landing it in and expecting this to sort everything out, because that's clearly not what's going to happen. But you know, the innovators, the suppliers that I work with through our accelerator programs at Digital Health London, you know, we're very much saying that this is partnership working.
Yeah.
You know, as the supplier of the technology, you need to understand that problem that you're trying to tackle, and then you work in partnership, you know, to overcome all of those different challenges. And I think that's the key thing. In terms of, I guess, where does technology fit with this, and does it save time? Does it help the workforce? Ultimately, yes, I believe it does. You know, if you can effectively change the pathway, you know, you can create those time savings, because you're taking away an element of work, which might be face-to-face work, and you know, using remote monitoring, for example, so that vital stats are kind of provided remotely, and actually then staff can look at that at the time that's, you know, convenient, and that actually they're reducing some of that face-to-face opportunity. So you're saving some time there. So there's time savings. There are cost savings, because actually you're maybe not having to run as many clinics, or actually you can get more people through the clinics. So there are definite opportunities to save money, to save time, and then ultimately, I guess, as long as that's been handled and managed in the right way for the staff, then you should hopefully be improving job satisfaction, experience, morale, you know, taking away some of that, I guess, maybe drudgery of a role that, you know, where it just feels like it's just never ending, and things are just not seeming any better. So good opportunity.
It is, Faris. I know you've spoken before as well, that the improvements that you've seen in your surgery. I mean, you just talk, it's helped here, it's helped here. Can you just remind everyone of where it's been a huge success for you?
Yeah, and again, we use a lot of digital, and then people often say, "Oh, you must be you're really digital first." I keep saying, "No, you're misunderstanding this. This isn't the case at all. We're really patient first, and so digital becomes an enabler sometimes of creating better services for patients. It's where is your focus, and this is kind of like that cultural shift that we really need. Like we kind of like Gail, you mentioned the Amazon like culture, the Amazon Prime culture. Well, sometimes it sounds a bit like that, doesn't it? Let's order an ambient AI scribe to do our notes for us, and away we go. Brilliant. And it doesn't work like that. We have to own the tech. The tech can't own us. And if we own the tech, then what we're saying is, what's the culture that we're putting around that? Well, it's about delivering brilliant care, and it's about looking after our staff so they can deliver brilliant care. And that's kind of what our focus has always been. So it's always been about, well, what technology can we bring in, but how do we make it work for us, for the patient, so we get the best out of it? And that involves work, but it really involves that overarching view of what is it we're trying to achieve. So, you know, for us, it's all about, look, access for patients is their number one thing, right? So if access is important, what do we do? Let's think about all the points of access. Telephones. Okay, well then let's look at the data. When's peak calling time? Let's staff the telephone so well that no one waits more than 1 minute to get through on the telephone lines. And that's what we've managed to achieve. What about online? Well, let's get everyone to use online if they want it, but not if they have to. So let's let them use it if they want. So what do? Let's open up online consultations, but let's take off limits, and let's take off hours. Let's let them use it 24/7 every day of the week, and no limits on it. So you open it up. So you're kind of giving them the best in-class experience of any way that they want to access the service. And then what happens? You actually push demand down. People aren't pushing against closed doors. They're not fighting for something they think they've got a right to, but don't feel or believe they have access to. So actually, you end up with a really responsible, respectable relationship between patient and service. Demand becomes controlled. You've looked at your demand and your provision of service, and you've matched them appropriately. Technology is great because, you know, online consultations have really been an enabler. Our telephone systems give us full data, you know, full access to data around peak waiting time. So IT has given, and technology has given us the data we never had before. Technology has given us scribes, ambient scribes. So clinicians are not having to type everything out, but they can look at patients and give patients a better experience, and patients walk away feeling like they've been listened to. So it's all this ecosystem, and tech is about enabling all of that to work better, cleaner, and more efficiently. But overarching, It's about working as a whole. It's about a culture within an organization.
And by when you were explaining it there, Faris, as someone who's a little bit, I'll probably say more on the concern side with data, you have my trust. And this is what we need at the end of the day, isn't it? Patient trust. Because, all these fancy tools, it's my health, it's my family's health, whatever, and I need trust. I need to feel safe and I need to feel secure that it's going to be okay. And Amanda, is this the number one priority? Because, we can go into sort of security and data sharing and everything like this, but at the end of the day, if there's all these shiny systems in place, I need to trust it. Otherwise, I'm not going to do it, am I?
I totally agree, and I think that we do need to give absolute confidence and assurance, and there's a lot of kind of things that we can do just to inform patients and give people opt out if they want to. Equally, I think sharing of information across the care pathway can really unlock a lot of improvements and benefits, and I do think the Amazon culture was mentioned. I do think, and Faris said digital should be an enabler. I do really believe that, because wouldn't it be great if people could really, whether it's through the NHS app as a front end or something like that, people can take control over their care journey. If they get a referral, they can choose their outpatient appointments, or they know where they are. They know where they are on the waiting list. They can see their test results, all of that. I think giving people much, as we would with banking, we know that there are, at some level of risk, but we trust, our banking app or what have you, we trust the security around it. And we can really do quite a lot to control our own sort of destiny really through that. And I would really like to see that in the NHS as well. I think there's a lot that the NHS needs to do to catch up, and there's a lot we can do across pathways, try and join up that technology, join up the information so people can see more. Because I think Faris made a really good point. Sometimes if you are worried about getting access, you're more likely to want to see somebody, have an appointment just in case your tablets run out or what have you. So I do think the more people feel that they've got control over their access of health services and the information about their own care journey, the better really. So yeah, it's a big enabler, but people do need to trust it and have confidence in it.
Totally. And I say this from personal experience. Unfortunately, at the end of November last year, my son suffered a stroke, and he's only 15 years old, and we spent the whole of December in hospitals. And you're right, that reassurance of knowing that what's next, what's going to happen, are we going to be seen, waiting for a bed in Oxford, John Radcliffe Oxford, and all these sort of different neurology and different departments and everything. And my son, he's been a superstar, but as a parent, it's just knowing and seeing it outside, you just wanted to go, is it going to be okay? Is everything going to be okay? And I don't know where to go sometimes when he's having a bad day, and it'd be great to just have that reassurance and stuff. And I think, and I know that digital tools can do that, but I still am unsure of what, how, where, and is that possible? But this is the future, right? This is the future. Do you think we'll have something like this in 5 years? Is that Mystic? I'm going to do a Mystic Meg. We had Mystic Mark on the last panel. Do you think within 5 years this could be a reality, that we will have this, Ruth? That's something you can have, that ability to share data, and everything will be working cross boards in the NHS?
So, there's lots of work going on at the moment around sharing data. I mean, and I think is that, the general public probably sees some of that from things like the NHS app. If you are in areas of the country where there are good, data sharing initiatives happening, when you go to A&E, for example, then, you may well find out that the team there has access to your clinical records from your primary care side. So it is happening. I think it's just how we kind of communicate that to the general public is really quite hard, and so it may just not be so visible. Certainly across London, which is where I work, there's a lot of work going on with an organisation called One London around how we make sure that all of these different data sources are all joined up. So it's very important. It's happening now, and I think it will mean that going forward, in the future, it will be easy to kind of rock up to any healthcare setting, and then essentially your records will be there for you. Can I just pick up on something you were saying about the I guess the data and the security and the safety and all of that as well? Sorry, jumping back a little bit, but I was just going to pick up around sort of, I guess, the governance and the robustness of the governance when for digital suppliers, essentially. So again, and this is something that the general public wouldn't necessarily see or know, but and maybe some NHS staff as well, but the procurement processes for getting digital solutions into healthcare settings are really, really quite strict. There are lots of compliance aspects that the digital companies have to satisfy around their, data sharing, around how they process data. So, there's so much that is set and that companies have to go through in order to be procured, whether that's, a pilot opportunity, whether that's a formal contract. And I'm sure Faris has kind of been through that in some of the procurement that he's been through as well, as Amanda. But, there is a lot that goes on to keep patients safe and keep patients' data safe.
Good. I know it's scary, and it's fascinating, but also scary that someone could just hack into it and know everything about me. Not there's an internet. They'd be a bit disappointed, to be honest. But I mentioned it in the introduction as well about predictive analytics, using digital for predictions and stuff, and we mentioned it also in the first panel as well. This is actually quite exciting. Balls and Mystic Meg it really feels like that today. Amanda, this is going to be a game changer, right? Is this the future of the NHS, predictive analytics and knowing, not only diagnostics, but also, I don't know you tell me, is this really where this is going to be an absolute game changer for the NHS?
Yeah, I mean, we are really excited about this, and I think the development of sort of integrated care boards and strategic commissioning, we are really looking at how we use predictive analysis, and we're starting to do that now. Yeah. I think it is really exciting in terms of planning, because you can put all different variables in it and look at different demographic changes, how we might influence demand, how we might influence activity. So I think from a sort of overall population planning perspective, it really enables us to target resources better, and also to see if we make some changes in pathways, what that could mean for different pathways, different demand, different patient flows. So I do think it's incredibly and performance, actually, and waiting times as well. All of that can be modelled through. So it's certainly something we are very much looking forward to, and we are starting to do that, and also tracking across the whole pathway as well. So yeah, it's very much in our minds at the moment. Yeah,
there's no point predicting if you're not tracking. So
yes,
haven't you? And Faris, is that the same with you? Is this something that's going to at the forefront with you and your surgery? Is it predictions and sort of trying to look into the future, what may happen?
Yeah, I mean, I might bring it back down to 2026 and say, I'm not hearing something that's a game changer. I mean, look, basically, you can put the best data in the world, through any system, but if the system's not working right, the data's not going to give you the benefit that you think it's going to. So, in order to create a good functional system, the more high quality data that you've got, the more chance you've got of building that better system. So yes, definitely. But the data's already there, and we have tons of, in primary care, we've got tons of data, and we're getting more and more data all the time. The honest truth is, it's having people who understand what the data means and what the data's telling them, how to interpret the data, and how to, let's say, translate the data into meaningful change. Now, that's a different ball game. You can find all the data you want, but unless you really have that culture around change and transformation, you have the tools you need to enact that transformation, then actually the data will just come up against a brick wall. And I think I've seen it far too often where people have got the data, but they don't know what to do with it and how to translate it. But if you create the right systems, then the data flows into the systems, and it has power and potency.
Right, I got you, because of the panel before we had Mark, who was he predicted, but he was never interpreting what they had. Right.
Exactly.
So there we go. So there's pros and cons of that. I mean, Ruth, from your point, is it do we have enough people interpreting the data that we've got at the moment, or is it a lot of it going on to predicting the future?
I mean, I probably can't talk to the roles around that. I mean, I think if you go into any large kind of NHS provider, that kind of IT kind of analytics aspect is a really strong component of that organisation. And as Amanda said, if you start thinking then at a kind of population level, ICB kind of thinking, that's where that planning is coming into force. I think there's also something about, I guess you've got the population level kind of prediction, but actually taking it down to, service level prediction as well. So there's been lots of work around, how can we understand the data around theatre utilisation, for example, so that we can better predict and we can better manage theatre use, which again then has that knock-on impact to kind of wait times and getting kind of more surgeries through that process. So I think there are different ways that the data is being used in that way. So yes, I think it's increasingly becoming more relevant, and I think important to have the right people who can understand that data and do something with it.
Yeah, and not only to understand the data, but also to use the tools. So we keep giving people in the workforce, and this, it seems that this comes up again. Is how do we keep the workforce engaged with using tools? Because it must be. I mean, it's supposed to be easier, but to relearn something and to go back and do something, I would, I'm bad enough with a new app on my phone, and I've got to reset, just get used to that. Are we doing everything we can for our workforce to help them be digital literate, or could more be done?
Maybe I can say something about some of the programs that we lead as well, we deliver. So we're really looking to support, I guess, the digital leaders of the future. And by digital leaders, they could be somebody who is, working within a clinical team, but is trying to implement and drive forward a clinical application like an app or some kind of software. It could be somebody who's working at a much more strategic level to bring in that digital kind of policy and strategy. And we deliver programs for the workforce, and we've done that sort of pan London, we've done that in a trust, we've done that across an ICB geography as well, to really give those individuals the knowledge, the skills, the abilities to kind of be the people driving digital forward, be those spokespeople, be the advocates, understanding, not just that there's this nice shiny app that, or system that they want to bring in, but, what do they need to be thinking about in terms of the procurement opportunities or, other aspects of governance, or thinking about the change management with staff. So I think having champions, having people who have the skills to lead on digital is really, really important. And, then it's about how do we make things simple ultimately? And I think that's the challenge of, for the suppliers, for example, that I work with, is it's creating technology that's usable, that has a nice friendly interface. And that sounds really simple, but I'm sure we've all used technology, and I've certainly used quite a lot in the NHS that don't have nice friendly interfaces, and they're really difficult to use. So by working with industry, with working with startups who are kind of really creative and are building really attractive and usable technology, I think we're halfway there to making things easier for the workforce as well.
Yeah, I think you're right, Ruth. Faris, how about you? Is this something on the forefront of your mind, is trying to keep everyone on board and sort of happy?
Yeah, I mean, it's a really interesting one, isn't it? And I'm just trying to think. I like a good analogy, but look, if I put in your kitchen the best pan, the best knife, the tastiest eggs, and the best cheese, right? It doesn't create its own omelette. Yeah, there's someone that needs to put those ingredients together. So you need somebody that's going to bring all of that together, so you can bring the best technology solutions, and they can speak to a solution. But unless someone's actually thought about how are we implementing it, how are we using it, how are we making it really easy for staff to use? And how are we making sure that it's not duplicating something they're doing somewhere else, etc.? Unless you really do that well, then things may work, but they may not work as well as you think. I've heard hospital consultants in one hospital say how great the Epic EPR is, and doctors in another hospital going how dreadful it is, and the only difference is how well it's been implemented. And it's that bit that makes the difference. So we need to make sure that when we're introducing anything new from a tech side, we've got the right people with the right eyes. So I would say, I feel really fortunate that, I've got an interest in digital. I speak to some great companies who are developing new technology, but I'm also a GP who does the work on the ground and can kind of understand how the bits fit together. So creating an implementation plan becomes really straightforward. And actually, we need that everywhere. We need clinicians to really be leading implementation of technology because they can see both sides of the equation. And I think that's where things fall down, is if we don't get that bit right. But if we do it right and we make sure that, when we're bringing something new, it's considerate of the clinician and the clinician can use it with ease, we've got a great chance. One thing that I think is really brilliant and that I really enjoy is working alongside the digital technology company. So we've got some working with us in practice. We're rolling out their product as a pilot, and actually we're saying, look, this isn't working. They go back, they tweak. And we've got this iterative process of saying, this works well, this isn't, tweak that, let's go again, tweak that, let's go again. And by the end of it, you end up with something that's working for everybody. So we've got to have a real open mind when it comes to technology. Deploy it well, have an iterative process. Don't be afraid to go back, change things and try again. And always with the clinician in mind and the patient in mind. Those are the people that matter most.
And it's that shared practice as well, Faris, like you just said. Like, if you don't know, you don't know what's good or what's out there. And do we do enough of it? Do we not? It's all right bringing our staff and the workforce and our colleagues on board and the digital leaders and everything, but how do we know that something else isn't, is working better? It feels like, again, we're all in our little silos, little pockets of everything. And is there enough reflection and talking with each other about tech and digital tools and how this is work? Do we celebrate, like Faris, like, right, we've done this really awesome, we're working with this digital tech company, who wants to know about it? Do we do that enough in the NHS?
Yeah, I think that's a really good point, because I think there is a lot more we can do, and certainly what we're doing across our area in the Midlands is we're trying to get more of a coalition, and we've got a sort of digital collaborative that is really looking at that, and partly how things interface, and also with councils as well, not only with the NHS, but with the health and care pathways, some of the complex hospital discharges. So, and getting the systems to talk to each other, getting a kind of what I would call one version of the truth, because that everybody's looking at their bit of data, but when you put it all together, you can get a really different picture. And that can really drive different conversations across whole pathways, across different sectors and things. So I think that the collaboration piece is going to be really, really vital. One of the things I'm really sort of conscious of is that we are a national health service, and people should be able to recognise the services that they get. And just thinking about some of the sort of .gov sites and services, there's a really common front end, and again, I think that it's great that we've got innovation in pockets, and I think probably a next step is to think, how do we join that together? It might be scaling things, it might be making them work together better, so that sort of front end for the patient and the clinicians actually, because that saves, protects really valuable clinical time. We should really try and do that. I think also the point about there's lots of information and people don't always know what to do with it. We're really conscious that our analysts they do need a really good sort of career structure, development support and things like that, because Otherwise, we won't really have people that can curate, can overlay data sets, can actually interpret and help drive some of that sort of transformation and change. So I think, yes, we need to collaborate around the digital products, but I think also let's value our analysts as well, who can curate that and help join together the information as well.
Just a quick question. How do you go about, do you guys think of the problem and then ask someone to solve it? How does it all come about with or does someone come to you and go, oh, we've got this and this can help you with that? Do you come up with the problem first and then someone comes up with a solution, or does someone come up with a solution to try and help a problem that you didn't know you had?
So I work with innovators who, and there's a mix on that side. So you get innovators who come to you with, I've got this amazing idea. It's going to save the world. You know, this is going to be the panacea that sorts everything out. And actually, they haven't linked their solution back to any problem.
Got you.
And that's the sort of starting point for us, is saying you need to be problem kind of focused,
Right.
and then build your solution from that. But what you also get on the flip side is we see a lot of innovators who have built their solutions because of a lived experience that they've had.
Yeah.
Therefore, you know, there is a real problem, or that, you know, that they've seen somebody else experience that, or they may well have been a clinician who's experienced that. So a lot, I think, to Amanda's point that it's mixed, I think that's absolutely true. But certainly the work that my programs do with innovators is saying this needs to be grounded with a problem. Otherwise it's not going to fly, it's not going to go anywhere, and people aren't going to be interested because there's no reason.
Exactly. Right. I'm going to just do a little bit of a sort of general question for you, just a bit of a hold it out there, and I'm not going to hold it to you because it's a bit of a predicting the future. And then we've got some questions from the audience as well, so I'll go through those afterwards. But if we were going to have this panel in 5 years' time, what do you think we would be talking about when it comes to digital tools and wait lists and everything like this? Do you think we'll be having the same conversation, or do you think we'll be in a different position? Amanda, I'll start with you.
Yeah, thank you. I really hope we're not having the same conversation. I do think the time is right now. We've got the 10-year plan for the NHS and through the 3 big shifts in that, and one of them is analog to digital. And I do think we've got a real opportunity now. I think we've got AI, we're sort of at the foothills of using that. We need to obviously make it work for us. But again, I think that can help with automation, pattern recognition, assimilation of information. It can potentially save a lot of, really valuable time from clinicians and others. So, and I think we've got the NHS app now. People are, we're doing a lot of work locally trying to get people to upload it, to understand how to use it, sort of have that digital inclusion there with our communities, and bring it on board. So I think all of the ingredients are there now, and it's up to us as leaders now to make those ingredients work and produce something that's, really beneficial. So I very much hope in 5 years' time it's a very different conversation.
Okay, thank you, Amanda. Ruth?
I completely agree. I think we've got some really strong examples of technologies that can support, reducing wait lists and improving access for patients. I think what we need to need to get sorted out is how we fund that. And I'm not saying it's about ploughing more money in, although that's obviously helpful, but it's about redesigning the pathways that we have so that we're freeing up money to be able to implement digital.
Nice. I'm Faris, you're nodding away there.
Yeah, and Ruth said the word redesign, and that's the key, and that's the one I'd pick out, right? So, I think we will have the same conversations in 5 years' time. Personally, yes, I do. I think that the situation may be less acute in 5 years than it is today, because even the passive use of technology might make some of this better. There is the NHS 10-year plan, the concept of integrated neighbourhood teams. So there is a shift now to understanding the problem. And I can say for sure that you've got primary care, secondary care, and the interface between the two doesn't work or function very well. And the idea of integration is to create a smoother transition between the two and better working between the two. That will overcome much of the problems that we've got around capacity at the moment, because there's too much inefficiency between the two primary, secondary care that's generating too much friction, heat, and therefore inefficiency. The problem, I think, is just more around, yes, it's about redesign, and actually we might have change on paper, but do we have cultural change? It's cultural change that we need. And you can talk as much as you want, but talk doesn't necessarily change culture. And my concern will be that NHS England and the 10-year plan is ignoring the opportunities for innovation. It's very much top down. It's very much about this population size. It's very much about certain organizations delivering. It's all about, merely sustaining the inflexibility that we've got today. So the success will depend upon how well NHS England is able to stimulate innovation, change, and redesign. And if we keep doing the same things we did in the past, it won't work. And me as a GP, I'm saying that I'm not being enabled at all, really, by the 10-year plan at the moment to help be part of that integrated solution. So that's what's going to be really key.
Yeah, completely. Right, thank you so much, guys. I'm going to just go through some of the questions that we've got in the question box. I think it's one for you, Faris. Have you answered it or no? I don't think you have. What AI tools will you recommend for other GP services to improve their processes around patient accesses and experiences?
Oh, that's a lovely question. So AI, this is really tricky. So AI is obviously the vogue term right now, but I still think at the moment, when it comes to digital, there's still old-fashioned technology that can still make a big difference. So RPA, robotic process automation, there's so much manual work we do as humans that could be replaced by computers doing things. So we're using more and more RPA, robotic process automation, that's creating humongous efficiency for us. Now, that is just you tell a computer what to do and it does it and it follows something. It's not making decisions. So from a governance side, it's very much more simple. So even before we get into AI, there's still so much we haven't yet adopted that we probably need to adopt. So automation around patient registrations, automation around the creation of test requests and patient recall systems. These are big hitters that save a lot of time. When it comes to AI, the governance gets more difficult because you've got something that can potentially, suggest you do things. So the governance gets a little bit more complicated, but I think AI ambient scribes are the big one around right now. They're saving lots of time. I think they're brilliant. So ambient AI scribes, I use it all the time and it's making my life so much better. So I think that's really good use of AI. There's something around AI triage. We don't use it, but maybe if we build confidence. Reception capacity, some of the solutions around AI receptionists. I'm not there yet. I still like human first, but that might change that dynamic and paradigm slightly. So we might get that there. So I think at those points, AI might be good. And why not use AI to maybe look at, previous patient interactions and identify patients who are at higher risk of other diseases? That's something to be said. AI is a really good way of also interpreting data. So where we have big data sets, can we use AI so that we can maybe tailor our services, identify unmet needs through that data? So there's a few spaces there where AI will be useful, somewhere it is useful right now, but actually let's not forget other technologies as well that we could be using.
I feel like it's again what I said at the start about that Amazon Prime. We want Amazon Prime until it goes wrong, and then we'll be first to blame Amazon Prime. Do you know what I mean? I feel like it's quite on the edge, isn't it? I mean, we've got a couple of things about what you mentioned about AI and triage, and I just thought, oh my gosh, that's so right. Because what if it's wrong?
Yeah, exactly right.
Yeah. And I don't want to put a doom and gloom on the last thing that I've just said, because that's just, but we're the reason why we're talking about these is these are people's fears, these are people's concerns, but with the right people in place, this will make a huge difference to NHS. And we talked about tackling those long wait times. We talked about, sort of technical solutions, virtual wards. I love the fact that this is something that we're championing as well.